This school has been put up in your honour. Would you have ever imagined anything like that happening?
Absolutely not. Absolutely not. I mean, I've been involved in education of nurses and medical assistants, etc., for years and years, but I'm just thrilled to be involved in this way. One of the issues was these kids come from families so poor that they certainly don't get any breakfast, and there wasn't any lunch, and so we had problems with the kids going scavenging around, digging up people's groundnuts. So we worked out how to get them a bit of lunch each, and so they now get lunch, inverted commas. And this has radically changed it, because they now can all come. When I say lunch in inverted commas, at the present time it consists either of a chapati, which is a large fried pancake, or a mug of sugary maize porridge. And this has completely revolutionized it, and they get that fairly early in the morning, so they have enough strength to work and they're able to come. And for 250 kids, it's very, very simple lunch. It's something like £50 a week. What they've started is digging their own gardens, so they can start to grow at least groundnuts and beans. And even if they don't cook those, they'll be able to sell them and buy the flour, etc., for the chapatis. And the teachers came initially at an extremely low wage, even lower than the low wages of a normal primary teacher would get there. We've been able to upgrade those a lot. We've been able to increase the teachers, so there's now about a dozen teachers. And they're very committed teachers. They could get jobs elsewhere, but they're doing this at less than they'd get working for the government.
You're extremely successful in your eye surgery. Can you pretty much explain what is it that you do?
When, at the end of the Idi Amin era, I went back to train in eye work, there was really no eye service in Uganda at all. So we started as a mobile team. Well, a team, it was me and one assistant and one suitcase on the back of lorries and things, traveling around, sensitizing people to what can be done, how blind people can see again. And so over the last 30 years, that has developed into a very well-organized eye service. And it started, of course, with training at the lowest levels, training village health workers to try and get people with visual impairment to a worker, then training the lowest level of worker, building up, till at the present time, in our main training hospital, Ruhara, we're actually training postgraduate specialist eye doctors. So we've gone right from village health workers to postgraduate specialist eye doctors. And I and my team are still doing the top level, the eye surgery. And although much of it is done around Uganda on the static units, we are the mobile unit, going to places that are underserved or going to places where we have specialist skills that they don't. And the last 5 years, we've been starting to go once a year into Sudan, because they're starting at square one like we were 30 years ago with nothing.
When you first went out with AIM, would you have ever foreseen this as an area that you would have gone into and something that you would have developed?
When I first went with AIM, I was very junior and expected to go and learn on the job. I was due to go to Oicha Hospital in Congo. In fact, the week I arrived was the last great convulsion of the First Congolese War, and everybody was coming as refugees. So we started Kagando with refugee staff and refugee people. At the end of the year, Dr. Becker and his people went back to Congo and said, stay here and look after this. That was 15 years, including 8 of Idi Amin. So I was learning on the job without any supervision and really just learning opportunistically. We were just hand to mouth, day by day, doing what we could. And in fact developing services, because in those times I got interested in leprosy and eventually became the doctor looking after all the leprosy patients in southwest Uganda. We also started, which was a strategic service, what you can call Well Children Clinic. In other words, preventive medicine for children, immunizations, nutrition, at the same time trying to bring safer maternity to the mothers. Then when Idi Amin went and aid began to come in, I had the chance to change focus, and I had realized at that time that there was very large numbers of blind people in Africa who did not need to be blind and nothing to serve them. It's also an interest that I'd had since I was a student. So I went back, I went to Leicester, retrained started as an intern in the hospital in middle age, did the various exams, and so after this, in this 30 years, we've been We started it. Many other people have come in. The Sight Savers, CBM, etc., Lions Aid have come in. It's not me alone, but and we now have this very good eye service in the country available to ordinary people near their home.
And the staff, then, that you now you have how many with you?
My particular team, I travel around usually with 3 or 4. I have this other project, the Disadvantaged Youngsters, which is education of kids with disabilities or orphans or others coming from families who had no hope of educating them. That's been going on for, well, it started 40 years ago. And it actually happens that a large number of those, as they come up, decide to do health work and train as clinical officers and nurses. And in fact, my entire team at the moment is made up of boys that started as disadvantaged youngsters. In fact, I mean, one thrilling one, my main assistant when I'm operating, who hands me the instruments, I first met as a blind boy, about 18 years ago. He was one of the very first children we did lens implants on for cataracts, when it was still quite a new thing, even in Western countries. Helped him with education, and now, starting in blind school, he's my main assistant doing operations for blind people. One of the reasons I do the mobile work is we specialize in children. We go to areas where they haven't the ability to operate on blind children and do them. And yes, this is the AIM's repeatability principle. Before you go, make sure you're not needed anymore. And praise the Lord, I've lived long enough to go from training village health workers to training postgraduate specialist ophthalmologists.
What kind of reception do you receive from villages?
Oh, hugely acceptable. I have to say, when we go to most places, we don't go to the villages, because you see, with having built up the system, there will be a team on the ground every place we go who have saved up the things they can't cope with. So that as soon as we arrive, a few minutes later, the very people that need our services are there for us to see. So it is very strategic. So our specialist skills can be put into use half an hour after we've arrived.
Your own work has been greatly recognised within the medical community as well. Can you tell us about that?
Well, the secular honours from Her Majesty, I'm not sure whether the missionaries should have it. The one that I think, in a way, thrilled me most of all is that I became an honorary. I had the fellowship of the Royal College of Ophthalmologists. It's one of the fellowships I have, but about, 4 years ago, I was elevated to honorary status. And I think the thing that thrilled me about this was that there's a very limited number of honorary fellows. They have just a few. Most of them are the big retired profs from the big medical schools in Britain, and with little me from the jungle. Now, the thing that thrills me about that is that the great big medical world is at last realizing that the two-thirds world is this huge unmet need, and that it's our responsibility here in the Western world, we the haves, to take this into account as well. And I have the honor of being kind of to represent this interest between the developed, the world of the haves, and this huge, huge world of the have-nots, with these huge, huge opportunities. You know, just take cataracts. The figure is something like 20 million people in the world blind with cataracts. And in 10 minutes, we, in a remote place, can give them normal sight. And it is just a scandal, in a sense, that this is the case. Fortunately, the scandal is being addressed. And as I say, just because of the timing, when I came in 30 years ago to the eye work, I happened to be one of the pioneers of this great movement to attack avoidable blindness. And it's a worldwide project, and we had the good fortune to be on the ground floor. In fact, I might say we were in before the ground floor. We started it before Geneva thought about it.
Can you explain what is the Waddell clamp?
Oh, the Waddell clamp. Yes, this is something we've been able to develop over recent years. There are several diseases picked out as main things to attack in Vision 2020. Cataracts, number one by far. As far as surgery comes, the second one is trachoma, because there's estimated to be up to 12 million people in the world, or 10 million people in the world, they're guesstimates, but it's umpteen million, becoming blind because of the scarring caused by trachoma, the eyelashes scratching their eyes, and as well as being extremely painful, it ends in blindness. we meet these people in the front line, and for something like 15 years now, WHO has been promoting a particular technique of doing the operation to get the eyelashes out from scratching the eyes. Now, this operation's been done for generations. It's never, in past years, it's never been terribly successful. The way we do it now, as promoted by WHO, is a much more successful one. But the technique which they were promoting in a booklet that they've distributed around the world was not good. It was very difficult. And one of the problems is because these people are so remote, the operation has to be done by non-doctors, even in some cases by non-nurses. So what I had been developing for about 10 years now is a much simplified way of doing the operation, which was quicker, safer, much more successful. And this hinges on this very simple thing, the clamp. And it's now in the public domain, and we have found that it is much easier, much safer, much quicker, and the end results are greatly improved. And we have taught, for example, into Sudan, to the place where we go, to a man there who I think has probably not even had primary education, but does beautiful surgery for this. The latest development with that, I've been working for some years with the Medical Education Department in Leicester Medical School, producing e-learning materials, electronic learning materials. And as a sideline, we produced a little training program for this operation. And in May this year was the annual Congress of the Royal College of Ophthalmologists in Liverpool, and you can submit your work. One of the things we submitted was the CD we have made, the training program for doing the operation. And to our utter astonishment, we won the prize for DVDs for this. And it's now being again distributed to all the donor agencies with the hopes that it will be widely spread so that people all around in these very remote places who have to do the operation will have a training program on an interactive DVD.
How is it possible then for you to do your work through funding?
I myself am supported through AIM International, of course, but funding for the team that I run doesn't come for that. It is principally funded by CBN. The other thing I need to mention is that I'm getting funding at present from Cancer Research UK, because I've been doing now for about 10 years research programs in eye cancer, because we have very large numbers there.
And just finally then, obviously you're with AIM. This work that you're doing is in partnership with AIM. What role does your faith play when you're out there?
I went with the Missionary Society, not with a government agency, because of a long-felt calling from, I think, boyhood, that this was my calling. And I was led to AIM, and after 46 years I'm very happy about that. I'm not sure I clearly understood what it involved, being a medical missionary. And I think I have to say that the experience, certainly in first years, was very hard. We had very little personal care because the people weren't around. Letters took weeks. There were no phones, no email, no etc., etc. And what I hadn't reckoned with is when you go to Africa as a health worker, you are surrounded by a sea of suffering. And although nobody's indispensable, the truth is very often it was me or us or nothing. And so you're faced day after day with people who are suffering, people who are blind, looking at you and knowing that you can help them and probably nobody else. But there's far too much. And this has been the great burden all the time, that the notion that you go as a preaching doctor, etc., very often has not worked out. One of my Ugandan colleagues said, we're called medical experts. The truth is we're medical nexperts. Next patient, next patient, next patient, next patient, all day long. Hurry up, hurry up. The queue's down out of sight. And yet, if you went away and didn't finish the queue, the people would be very hurt as well. And one of the things they actually value in us is that we are nexperts. We will go at speed all day long and into the night to make sure that nobody is turned away unattended. Paradoxically, what seems to us our failure as missionaries is often seen by the community, greatly to our credit. The other thing I personally began to look and saw that if you look carefully at the Gospels, a number of the healing episodes with Jesus counting healing people that are told in detail had a spiritual significance to them. But if you also look closely, there's a huge amount that clearly was purely humanitarian. Jesus was so pressurized by these people around him all the time. And I came to realize it's a very good New Testament mandate to take care of the physical needs of people, even if there is no visible spiritual evangelistic input to it at all. This is giving a cup of water to somebody who's thirsty, caring for somebody who's sick, etc., etc. So I think we all came to feel much happier about our position.
Dr. Keith, thanks for your time.